Divide and rupture, post-endoscopic retrograde cholangiopancreatography, splenic hemorrhage in an elderly man with pancreas divisum. Pancreas divisum occurs in up to 10% of the population and is usually asymptomatic. We review the pathophysiology of the development of recurrent pancreatitis and post-ERCP hemorrhage in an elderly man with pancreas divisum. A 70-year-old man with a 6-month history of 4 episodes of recurrent pancreatitis presented with 2 days of worsening abdominal pain, nausea, and vomiting. Evaluation was notable for epigastric tenderness, mildly elevated lipase, and CT findings of acute pancreatitis with a multiloculated pseudocyst in the region of the tail of pancreas. ERCP demonstrated a complete pancreas divisum with a dilated common bile duct, seen here by the red arrow in figure 1, and a mild pancreatic duct dilatation, noted as the green arrow, along with a fistula in the pancreatic body and tail. This was also associated with a distal duct stenosis. Sphincterotomy and sphincteroplasty of the minor papilla was performed with multiple sweeps and stents deployed into the pancreatic fistula. The next day, he experienced sudden abdominal pain, hypotension, and a 4-gram drop in hemoglobin. Emergent CT demonstrated interval development of a splenic subcapsular hematoma with hemoperitoneum, seen here in figure 2. Treatment was rapidly initiated with emergent blood transfusion and an uneventful splenic artery embolization. The patient recovered with no further complications. Pancreas divisum is a congenital anomaly in which the ventral and dorsal parts of the pancreas fail to fuse. This causes the pancreatic body, tail, isthmus, and accessory duct to drain separately into the minor papilla instead of the major papilla. It is important to delineate the entity from a false pancreas divisum, which is an acquired obstructing lesion resulting from the irreversible injury to the pancreatic duct during acute pancreatitis, with subsequent healing by scar formation at the site of duct injury. Whereas accessory papillary sphincteroplasty is effective for recurrent pancreatitis associated with true pancreas divisum, such as in our case, false pancreas divisum requires a distal pancreatectomy or pancreatical jejunostomy to overcome this irreversible obstruction of the main pancreatic duct. ERCP remains a gold standard in diagnosing this condition. The percentage of bleeding after ERCP ranges from 1 to 3%, with less than 30 cases of splenic bleeding reported in literature. Causes include direct trauma, bowing of the endoscope along the greater curvature of the stomach, avulsion of short gastric and/or splenic vessels, and splenic capsule laceration during adhesiolysis. Chronic pancreatitis may also contribute to this presentation by causing fibrosis of the splenocolic as well as the gastric ligament, increasing the traction forces due to these changes. Timely identification of splenic hemorrhage could be life-saving, thus it must be entertained when signs of hemodynamic instability or an abrupt fall in hemoglobin occur.